but we have some great sessions coming up. So come in and take a seat whenever you're ready. All right, we're going to jump right into our next session. The theme is food and health. How access to healthy food connects to preventing chronic conditions like diabetes or high blood pressure, and how hospitals and food partners collaborate to align funding, data, and outcome. Coming on stage is going to be Amber Starn, the Director and Division of Community Health and Evaluation at Charles County Department of Health. Whitney Ashead is the Director of Social Impact Partnerships and Growth at Hungry Harvest. And Sandy Washington, my new best friend, is the CEO of Lifestyles Incorporated. Please welcome to the stage.
And I will let you know that Sandy is everybody's best friend. And I tell people all the time, when I grow up, I want to be just like her or even half as awesome as she is. And Carmela. Both of them, I want to be just like them one day. So I'm Amber Starn, and I am the Director of Community Health and Evaluation at the Charles County Department of Health. And I am honored to serve today on this panel with Whitney and Sandy to talk about food and health and how we work together as healthcare organizations and community-based organizations to really address those needs in our community. So underneath of my division at the health department, we have all of our chronic disease programs, including diabetes prevention program, the Stanford's chronic disease self-management program, and diabetes self-management program, and building better caregivers. So we have a lot of community-based programs as well. And so getting those to the right people and the right populations in their communities is really what's important to us. And so I'll let the others talk a little bit about themselves as well.
Good afternoon, everyone. My name is Whitney. I am the Director of Partnerships for Hungry Harvest, and really in my day-to-day, I'm leading our Harvest RX program and building partnerships with community-based organizations, healthcare providers, and fingers crossed, a few healthcare payers to really think about how we can introduce food at the intersection of improving health outcomes. And so I've been really lucky to work with quite a few of those of you in this room, but also several other organizations in Maryland.
I think I'm on here. Good afternoon. I'm Sandy Washington, CEO and co-founder of Lifestyles of Maryland. And we've run a myriad of programs from housing, transportation, and really dealing with food insecurity. We have pantries throughout Charles, Calvert, and St. Mary's County. Our largest presence or footprint is in Charles County. We've been there for close to 30 years and providing gap-filling services and realizing that food is the joiner of everything. That is truly breaking bread, and the ability to break bread allows you to break down barriers and meet the needs of people in a community. So it's really the bread that keeps us all together. Yeah.
I love that. So question to the whole group here to start. Maryland counties are showing that prevention works best when it's personal, local, and data-driven. And I think everybody here can agree with that. From your perspective, what's driving the most meaningful progress at the intersection of food access and chronic disease prevention right now? Well, for me, I'm going to start out with the data part of it. I'm an epidemiologist by trade, so numbers are immediately what I think of. And for us, we heard about the community health needs assessment process because we know you can't have a program for us without us. And we have to hear what our community thinks. And we have to show the data about why those things are important and why they might work. And another great example of that is our mobile integrated health program. We have a lot of individuals who have those social barriers that cause them to use those most expensive forms of emergent care. They're calling 911 multiple times a day. or they're showing up at the emergency department repeatedly. So again, we had one that had been there 124 times in a 3-month period when we first looked. And we thought if we could reduce that person's utilization for even a quarter of that, then it would be worth the hospital's time. It would be worth emergency services time. And we could probably change their quality of life. And as we talk about return on investment, it's not just return on investment, it's return on health. And so improving that person's life. So it didn't take long for us to pull that data to prove that that program would be beneficial to all the parties involved. I think another thing that we just transitioning to that whole local and personal part of it, we have to be on the road. Not everything can happen in the brick and mortar buildings that we have. We can't expect everybody to come to us at the health department. Our programs have to be out there in the community. It's really important that we are at locations that are easy for them to get to. I don't know if anybody has ever traveled down to Charles County, but we're beautiful. Come visit us. But we have a very rudimentary public transportation system. Look on Sandy's face. Yes. And so it's not always easy to get around that way. So we need to have things at the libraries and we need to have things at the health department, but we also need to have them at the schools and the community centers and those places people can get to. That's really important. And then working with those community partners. I'm so glad to have Sandy sitting beside me because we have to work together because they are the ones that we've heard over and over again today that are trusted in our communities. They've established those relationships after years of working with people. And so we can pair up with them. There are times where we have gone out with them into the woods to give flu vaccinations, or we will be with them every time that there is an outreach day at the libraries. So partnering in order to make sure that it is a one-stop shop for them when they come to that location that day, that it's not just that day that they're going to be there to get a shower. It might be the day that they work on housing and they get protected for flu and they get harm reduction services at the same time. And we give them help assist them in signing up for a chronic disease program or our quit smoking classes. So now that I've talked about Sandy, I think I'll pass it over to her.
Yeah, thank you. You're right. Just making it personal with folks and getting information from people instead of, I think we heard earlier, instead of assuming we know what people need, finding out from them what they need. And sometimes folks don't even know what they need. You know, when you look at eating nutritious meals, eating a meal is getting a meal for some folks. They're not looking at nutritional value. They're not looking at any of that. I remember years ago, we would get food delivered and they'd have all this canned sodas and bags of candy. And I'm like, why are we giving this to folks that are already having trouble with diabetes and all these chronic diseases? And now we're giving them sugar cereal and all these other things because that's what was given. But when we start teaching people different things and being able to expose them to different things, then they kind of have some input because you've given them some knowledge and they can make choices in being able to do that. So hearing back from those folks what they feel they need, and then being able to pull the tools out of our toolboxes that we have to be able to say, here's the health department, here's a doctor, here's social services, here are other things that we can tap into, and being at all of those tables and bringing people to those tables to be able to be heard and really follow that, and then seeing the results of that. We are really good, and I understand assessments, and I understand the data is so important. We understand it more on the back end, but the person that's dealing with the symptoms and dealing with the day-to-day life, they don't hear about an assessment that they may not see the results of for years and years down the road. I mean, we do a lot of surveys, and people don't get to see the results of those surveys, but we have to think of what are they going to get immediately from this so that they see that the needle is moving, and then keep them engaged during the whole process. And I think as we think through some of these things, it's going to help us stay personal and relatable to the people that we're trying to serve.
And I think with that, Sandy and Amber talked about data and people. And I think the third piece that really starts to be empowered by the work that's done there is the policy. And so by being able to have that data on ROI, by being able to have those personal stories and being able to elevate the work that's happening with CBOs, with boots on the ground, and the savings that are happening with that, or the improved healthcare that's happening with that, can then be translated into policy. And so as we're thinking about really what's driving meaningful progress, it's a lot of advocates that have been doing this, like you all, for decades, and that are now being able to share that story and see those translated ROI impacts, and advocating with policymakers to see things like Medicaid 1115 waivers, or in Maryland, we're seeing, primary care program redesign, and community schools be supported. And so I think through people and data is where we see policy change, which is where we start to see sustainable funding and action that can take place.
Thank you. So how are tools, for example, ballooning health screening and follow-up capabilities, or other digital platforms, helping identify food insecurity earlier and connect individuals to nutrition or chronic disease programs more efficiently? Whitney, do you have an answer? Or Sandy, on either one of you on that?
I'm going to expose some vulnerability here, and I hope this is a safe place, right?
Yes.
Where's my friend from Vegas? Whatever happens in Vegas stays in Vegas, right? Okay. So I guess the vulnerability part is most of us that get into nonprofits, there's a passion for something. There's a passion for serving, and there's a passion to provide a need to our community. But we also have to know our limitations. And so understanding how to read the signs and read the data and understand what it means when you do that, being able to evaluate a program properly. And that's why most evaluators are in on the beginning of a program and not on the end of a program. And so being able to do that, I think many community-based organizations, smaller ones, and I consider myself a smaller one, may not have that capability. And so while we may know how to reach people, we may have a passion to serve, but we need help with how do you translate all of this into the impact of what you're doing? Are we really reaching people? I can roll off my tongue that we serve 17,000 people a year. Ask me how successful I am in serving those people. I probably can't tell you. I can say this is it because these people came to us hungry. This many people were fed. This is how many families we were able to reach. But were they really better off other than what they got that time when they came? I'm not able to measure that. And so when you talk about the data and you talk about that, I look at Amber and I read those reports that they do, and they show all of this information, and I'm glad that they can translate that. But I also think there has to be a way that as community-based organizations, we can feed into that more than we do so that we can see what the outcomes are better than we do. And I don't think we're capturing that as much as I'd like to see us do. And so when I talk about things like that, I'm like, we have to admit that we're vulnerable and that we don't know everything. And how can you help us with that and get through that so that we can capture those things, change legislation, look at policy that really works for the folks, and how that translates into helping people. Just one other thing, Governor Moore's opening, and thank you for that, he mentioned the Enough program. And we are proud, Lifestyles is a proud one of 27 organizations in the state of Maryland that we are an Enough quarterback in Charles County. And that has proven to be very successful because the governor is really addressing childhood poverty, and he's saying everybody that's going to go after any funding in Maryland needs to look at how you're working with the Enough program and how is it addressing childhood poverty. And it's forcing us to say to those partners, tell us what you're going to do. We're just not going to give you a letter of support. Tell us what part you're going to play in meeting these needs. And so it's making us all accountable. And this is where we see policy and legislation really working and feeding back to a community.
Yeah, I love that. And I think it's such a good point in terms of like actually being able to collect the data and reach the patients in a meaningful way. I think as a Hungry Harvest is a food delivery company, and when it comes to our Harvest RX program, food delivery might be the easiest thing that we do. The challenging part is the engagement, the marketing, the trust building, and making sure that we're really being a good steward of these patients' trust, and that we're reaching out and maintaining that relationship in a meaningful way, both with the patient, but also with providers, also with care navigators, and being a resource that they can trust and rely upon. I know we talked about consistency earlier, and being able to be consistent, really the data and the technology piece is really helpful in building and in doing that. And so while we're a food delivery company, there's so much that goes on behind the scenes before a patient even gets food from us. And I think that's where the data and the record keeping and the partnership building really plays a role.
And for anybody sitting here who's thinking about it, we are an agency who uses Blooming Health. And we are a small local health department. And that's exactly why we use it. So we are not your big ones. You know, I will tell you, I'm often sitting in conferences and days like this and thinking, oh, Baltimore City did it, but I'm never going to have the money to do that. Well, I'm going to tell you right now that in this situation, we were able to. And for us, it's because with all those programs I listed that we do, I have a dozen people. So we are working on 20 plus grants and a lot of other programs in our community with a very small staff to do it. And we don't have the time to do everything that we need to do for these programs and for the people. So for us, the key components are engagement and follow-up. Those are so important in health education. How do we keep those people engaged so that we retain them in a program that may last a year long? And then how do we continue with that follow-up? And we don't always have the time to do that. We talk about things like social determinants of health screenings. Yeah, but those take time. And you have to have the staff to be able to do that. And so for us, this was how we might be able to do some of those things that are being required of us now. In a lot of these grants, it's not just deliver this program, it's we need you to look at the equitable part of it. We need to think about inclusivity. You need to think about how you're delivering this in an equitable way. So how do we do that with the staff that we still currently have? Because we don't have any more people to do those things. So for us, we're incorporating this into this is how we can do that. And so we can send out those follow-ups to individuals, and we can continue to track somebody who might be in one of our blood pressure programs that needs to be monitored for the next 4 months. Or we can send out a follow-up to remind people in the diabetes prevention program that they need to send their weights in to us for each week, especially if there's somebody who's in one of our virtual classes and they're not coming in every week in person. So it just gives us the ability to do more with the current staff that we have. So for those in smaller organizations like us, that is really the big piece that convinced us that this would be worth our time and our limited amount of funding that we do have. For us, we also saw it as a way that people can answer the questions without eyes on them. We've noticed when somebody's filling out a social determinants of health screening that they're often looking back up at us. And are they watching my answers? Are they looking to see what I put down? And when they're doing it over the phone, or they're doing it by text message, or they're doing it in a link that they clicked in their email, there's a little bit sense of anonymity to it. And so they can be honest about their answers and their responses. And then from that, our response and the resources that we give them are specialized to what their needs actually are. So it just makes us a little bit better at what we do. So we'll just turn at this point. We've talked a lot on measurable outcomes and how do we measure what we're doing and evaluating. And so this one goes to Sandy. Lifestyles has built deep community trust. What have you learned about translating that trust into measurable improvements in things like blood pressure, diabetes, or other chronic diseases, especially working alongside your hospital or your local health department? That's a big question.
Yeah, it is. There have been levels of frustration when you feel like you've got answers and there are things that could change people's lives and um, they're not taking advantage of it. I thought about this morning when I was looking. I thought I wear this ring, this aura ring. It tells me my blood pressure, my heart rate, my glucose level, all of that. It does nothing for my chronic disease. It doesn't help my diabetes because if I don't do anything to alter it, it lets me know where it is. And I can track when my stress level went up. I can think back about what happened during the day that took that up. And then I could try to avoid that. I feel the same way when you're starting to deal with teaching people about chronic diseases and dealing with diabetes and blood pressure and all of the heart disease and all of those things. And um, I want to back up a minute because I have such a passion for our health department. 30 years ago, our organization started, and the first grant we received was from the Charles County Health Department for $250. And I was thrilled to death. $250. $9 million later, I'm still working with the Charles County Health Department. And they have taught us so much from diabetes education to community health workers, a number of programs. And what I've learned through all of that is even having the tools, you're breaking generations of living conditions, generations of things that have a way of living that you're trying to go in and change with different people. That's not going to happen instantly. Can I tell you what you write in a proposal doesn't necessarily materialize as quickly as you'd like? And the fact that we think that we're going to change generations in a grant cycle is not really realistic every time. And so there's a level of frustration and we always feel like we need to overstate what we're going to do so that we can get in the door to get it done. But really, we need to track it and take the time and take the small wins that allows us to do that. If somebody maintained their weight loss for 90 days and or 3 months or to a year, I call that a win. If somebody changed their diet and they're changing their diets for their children and they're learning what the plate size means and all of those things, those are wins. But we really don't look at the wins. We go to the next thing instead of really looking at those wins. And so I think what I've learned through that is that there's a balance of being with those that have the knowledge, our hospitals, our health departments, our physicians, our behavioral health folks, and then being with those that are in need of the service and those that even don't know they need the service, but you want to change a lifestyle, and being that intersection of being able to bring that together, bringing the tools there, and being in those places. We talked earlier about knowing that everything is not in the brick and mortar buildings. The uniqueness of Charles County is that 18 miles from the nation's capital, we have places without indoor plumbing and running water. And so we together deliver water and put porta johns in places so children can have a place to go to the bathroom. So when you talk about nutrition and being able to provide a meal, you first have to look at basic needs. Is there running water? Can they bathe? Can they wash? During the pandemic, when we were dealing with wash your hands so many times, and we have people that don't even have running water, that was not just a given. And these were folks that we band together with our hospital and our health department and took resources into our communities, and we're there to hear them and be able to share information. So while we're looking at chronic diseases and long-term effects, we're also dealing with the here and now. And I think you have to be able to balance both of those things, the here and now and the long-term effects.
Yeah, because we've learned those social things. You might have to deal with, you might be there because their diabetes is out of control, but first we need to deal with the bed bugs in the house before they can even think about those things. So yes, coming back to that hierarchy of needs. And just because they don't have any running water in that house and they're living off of the electrical cord from the neighbor's house for any electricity, it might be the cleanest house you've ever been in. And so, yeah, keeping that respect and for those individuals and helping them where they're at first is really something we've learned a lot of with working with Sandy, working with our mobile integrated health program as well over the years. Whitney, from the food as medicine side, how are you measuring the return of an investment for programs like meal delivery or produce prescriptions? And what data or stories best demonstrate that food truly is medicine?
I think ROI is quite literally the $1 million question
Right.
that I wish that I had the answer to, but I will do my best to kind of share some of the things that we've heard from our healthcare providers or health plan partners that they're really interested in. We often hear a lot of metrics around readmissions to the hospital. I know that both of you have spoken about that as well. That's a really huge thing that payers are looking to save money on. We've seen an interest in maternal health outcomes, improvements there, but also HbA1c, weight reduction. But overall, we also see an importance in reducing food insecurity. And so we've seen that the integration of food, especially when you're designing that food to meet people where they are, is really meaningful. We've done some pilots with folks that have seen a 95% improvement in food security between people reporting how food insecure they were on a spectrum over 6 months of receiving produce. But we've also seen improvements in engagement and retention. Those are other places where health plans are looking for metrics and outcomes. We've done some pilots with the YMCA in DC to look at if people are in a 12-month lifestyle program and they're given healthy groceries or food to pair up with that program, that they're more likely to stay in that program. The engagement rates for that whole 12 months is around 65% when they're given that incentive to stay and participate. And so I think we've had to get really creative in these ROI discussions because there's really no wrong door right now whenever we're thinking about what's most important, and what's most important will differ based on who you're speaking with. The one thing we were also chatting about at lunch was that not many other services or medications are asked to provide an ROI. When there's a new medication, a payer might fund it and there's no conversation around, well, how is this going to give me a return on my investment? We're more so looking at the return on health. Is this a good investment because this medication makes somebody's life better? It improves their health outcomes. They're less likely to be in the hospital. And if the answer is yes, then let's fund it. And so ROI can be, it's kind of this big elephant in the room, and we've seen a lot of studies that have proven that it's impactful. One example that comes to mind as well is the Medicaid 1115 waiver in North Carolina, which allowed Medicaid beneficiaries to receive social services that were reimbursable by Medicaid. And that showed an $85 per member per month savings for the health plan, just by being able to get some of these basic resources into people's homes. It's not just food, it's also housing and really meeting people where they are. We know that the ROI exists. A lot of it is framing that conversation and really trying to understand what's most important to the health plan at that time. But there's some really great momentum that's happening on a policy level to see that ROI really taken seriously, and the work that community-based organizations have put into building trust and relationships and outcomes be funded at a larger scale.
We also realized that we were in our community supported agriculture program and things like that, where we're giving out these produce boxes or we're having our diabetes prevention programs, and we realized that just because we gave them the produce doesn't mean they had any idea how to use it. And so we had to start adding in things like cooking classes to teach people how to use it, things on basic as knife skills. You can give them a pepper, but if they don't know how to cut that up, then it's not useful. And so incorporating beyond that, here's the meal, here's what you can do with that. And so again, working with those community partners, can you have the Maryland Extension there with you when you're giving out boxes at a farmer's market to teach people exactly how to use the food that they're getting that day, and then sending them home with those recipes? Or for us, we're offering family cooking classes so that everybody in the family learns how to make that particular meal, and that they can see that everybody can play a part in healthy eating. And going back to some of the sustainability parts of it, I know we've talked on policies a lot, and Whitney was beginning to speak on that. We know that a lot of these programs depend on those short-term grants, like the $250 that she got from the health department. We might offer just a little bit more these days, but still it doesn't go as far. But what are funding models or policy changes that could make these efforts more sustainable and ensure that food and nutrition services remain core parts of Maryland's health ecosystem? And I know for us, we're starting to look at insurance reimbursement for our health education programs. And those have their pros and their cons to that. And that gives us another source of funding for a public health agency or a healthcare agency who are offering those programs beyond the government, when we know that with every administration, priorities change and funding levels change for us for different programs. But on the other side of it, they have to be fair and reasonable reimbursements, because right now I could tell you that for things like the diabetes prevention program, it is not enough to run that program, what we're getting back in reimbursement. We have to absorb that cost either with core funding that we get on a county or state level, or from another grant that we're receiving. And so we have to figure out ways to make it more sustainable for us. And for us, now we have to think more on these non-traditional partners that we haven't really looked at, and maybe more of those public-private partnerships than what we've ever had before, because we have been so reliant on governmental agencies who support us, or our traditional partners like the hospital or health systems in our communities. But we need to look at things like the businesses and realize, telling them not just the ROI, but remembering these employees are with you a lot of their waking hours. And the healthier they are, the more productive they are. And you want them to be healthier, you want them to be happier when they're employed by you and when they're there during the day. And so there are benefits to them in working with us as well. And so for us, we're trying to expand our reach and our partnerships to people like the Chamber of Commerce and some of our businesses that we didn't really explore previously, but now have other opportunities to do.
Well, for us, we have been looking at diversifying income as much as possible. About 80% of our funding is from state and federal grants. And that's pretty scary, considering also that they're all reimbursable grants. So if they're done on a quarterly basis, you're working 3 months before you can bill. The 4th month you're billing, they've got 30 days to pay you. So you're pretty much gone a half a year without any funding coming in. So you're looking at other funding to sustain. It's really challenging with community-based organization. That trust is really, it's really the vein that runs through things. If you think of it, you build trust in a community, but then you take on a program that's funded by the government, and then what happens when the funding is pulled? When you have communities that are accustomed to things coming and going, you will lose your trust if you get them engaged in something and then you say, it's no longer here. So one of the problems that we've had throughout the years is that we don't want to put something in and take it out. So even if the funding stopped, we have to find a way to keep it going. And thank goodness we have built enough trust in business community and in donors that have been able to subsidize where we've had to stop government funding in different areas. Not enough to take care of the 80% that we're still funded. So we're looking at other avenues. How do we do this? How do we work on this? But at the same time, we think we have a commitment to other community-based organizations and nonprofits that may be smaller than we are. And so to look at the capacity of our organization, there's not so much you can do with the funds you have. So we've started thinking differently. How do we take a grant that we get and take a portion of that and give that to smaller organizations that may be closer in the community? They can carry out the work, they can continue to do that, and then we help to build their capacity while we're doing it. And so we've done that. We've probably got 7 counties in the state of Maryland right now that we are funding groups in those counties to be able to meet those needs. And through that, we're able to gather more data and be able to feed that back into additional funding from private donors, folks like Kaiser, United Healthcare. All of those folks are being able to look at what we're doing, and they've been willing to support initiatives that we have and putting that money back. We need to look at other ways to do that. Because we don't have a fee for service, if you will. So because of that, somebody has to fund it. I always tell people that we serve, there's nothing that you get that's free. Somebody's paying for it. And so we have to look at who can pay for what we are providing that's benefiting the community.
Any others?
I think you all nailed it. Kind of with that sustainability piece, I think we want to see, and we talked a lot about payers. We talked a lot about the data that's meaningful to them. I think one thing that gets me really excited when I think about prevention is starting early. Maryland specifically has programming within the concentration of poverty grants, which allows community schools to have a certain amount of funds that provide services outside of academic ones. And we talk a lot about this problem when it's already happening, but how do we prevent it? How do we get people food and access to basic resources before there's this incredible need for it, before people are sick? And I think when we consider policy, the Medicaid 1115 waivers or Maryland's primary care programs are really meaningful levers, but I like to think about what the state can do 20 years before that problem even comes to the surface.
Can I just add to, you talk about community schools and some of the resources. When we talk about increasing sustainability and the income, I think there needs to be an inventory taken of what we have already. I have seen places that have resources in the same school, but one doesn't know what the other is doing and they're not connecting. So you've got all these resources there, but they're reaching outside of themselves to connect with the resource that they already have internally. So I think assessing what we have and being able to make sure we're making the best use of what we have already, and then identifying those gaps and working together to fill those gaps. It's all right to say, Lifestyles, we don't need you to do food pantries anymore. We have enough food pantries. That's okay. Then we can shift our vision and our energy to something else. But we have to be willing to say that. As we were going through all of this crisis and with the SNAP benefits and more people, the federal layoffs and people needing more food, we have Southern Maryland Food Connection, and it covers all of Southern Maryland. It tells you what pantries are available, what soup kitchens are there, who's doing a food drop. And what we said on a social media post was, all of the food pantries need food and donations. Take it to your closest food pantry. We didn't say bring it to us because we don't want somebody traveling all over to come to us, but take it to the neighborhood that needs it. And we have to be willing to say, take it to the folks that need it because they're closer there. They can do that. That church is in that community. Can you help that community and do that? Yes, we could use it, but we need you to do that because now we can see that helping. When we're able to, people realize that you're able to do that and you're just not trying to gather everything to yourself, but you're really looking at outcomes. I think the trust just continues to build, and we need to be willing to do that.
I love that. Future visions. We've already started this conversation. We just moved ourselves right into it. If you could design the next major innovation or policy in Maryland to link food access technology and chronic disease prevention, what would that look like?
Blooming Health.
And yeah, they love that answer. Yeah, It's for me. It's also Zach isn't here anymore, but he kind of asked this question this morning of how do you work with those insurers? Well, for us in Charles County, we're also looking at blue zones. And I'm not sure if anybody else in the room knows what that is, but those are those places in the world where people live to 100 or greater. And they studied those areas to see what are those commonalities among those populations that lead to a longer life expectancy and greater years of quality of life as well. And so for us, we've been looking at that for our food systems. So we've partnered with them. We did a readiness assessment to see what are we ready to do this and what are some areas that we could work on. And for us, they were like, you need to work on a lot of those policy changes and capacity building and within our county. And so I was hoping Zach was still here so that we could have a chat with him and care first about how some of those things could work. We could all work together on some of those things because it really is transforming your entire community in order to make that happen. It's not just, part of it, but not just that, but working with between your farmers and your school systems to get that local food into the schools and working to have your community gardens and people seeing the value of growing their own foods and eating healthy and really just changing that whole dynamic within the county. And that's where we want to be. But we need more partners to make that happen.
I think in terms of an ideal vision, I would love for it to be able to start any program that focuses on health and food to start early and not punish people for when they get healthy. I think we often see programs where people are eligible if they have 2 or more chronic diet-related chronic conditions, or they meet a certain area deprivation index number. But if there's improvements, if there's health outcomes that are achieved, that funding stops, that eligibility stops. And so I think being able to see a program that tries to address the problem before it happens and then also doesn't punish success, that's really, I think, an ideal space where a program can be sustainable and also have manageable outcomes without seeing people fall off of it for no good reason. I also think it needs to be comprehensive. There needs to be a registered dietitian or a community partner that can pair your food with cooking classes so that when you do get that food, it feels meaningful and it's designed with you in mind and not as a bottom, a top-down solution. And then I think ultimately that can lower the rates of chronic disease. And I think ultimately that lowers healthcare costs and creates a sustainable solution. That's my dream. Maybe we'll get there someday soon.
Yes, and when we give people those cooking classes and that food, we take their culture into account as well. So we have talked our whole entire time off because we were having such a great time. When we got up here, we said we're going to come up here and have a conversation, and we really did. So I want to thank each of you for joining me today and having this conversation, and to thank the crowd as well. So thank you.